Assalamu alaikum wa rahmatullahi wa barakatuh. Very good evening. Welcome to Health Matters. I'm Khawa Solomon. We'll be with you for the next hour with your health questions. Very important one as we focus on Thyroid Awareness Month. It is still January, just a little bit left of it, but it is Thyroid Awareness Month. We are opening the lines, so please do interact with us if you have any thyroid questions. In studio with me, Dr. Wadi. Dr. Shoaib Wadi, how are you doing, sir?
Assalamu alaikum wa rahmatullahi wa barakatuh. How are you, Khawa?
Good,
Thank you once more and welcome back to 2019.
Absolutely, yes, welcome. The first time I'm seeing you for the year. Hope you had a good one,
I did.
A healthy and rested one as well.
Well, we're almost 1/12 of the way through, so that's fine.
Alhamdulillah. But the focus on the show is our endocrinologist in studio with our specialist physician, Dr. Sandeep Ruda. Thank you so much for joining us, sir.
Assalamu alaikum and thank you for
Wa
having
alaikum
me.
salam.
Yeah.
It's a pleasure. So tell us a bit about yourself and how long you've been in the industry.
So I've been a doctor almost as long as him, maybe a year or two less.
Okay.
So we've been doing endocrinology for many years. Endocrinology is the field of the study of the hormones of the body.
Mm-hmm.
So we deal with thyroid disease, diabetes, female hormonal problems, male hormonal problems, a variety of things.
Okay.
But very common, and the topic for this month and today is thyroid disease.
Yes.
So we'll be discussing that today.
Absolutely. Dr. Wadi, your introduction to the show, inshallah?
Yeah, look, I think obviously I like to paint an analogy. So we know that Sandeep is talking about hormones. So hormones are substances which are produced in one part of the body and then act either in that part of the body, but usually in another part of the body. So the thyroid hormone, for example, will be produced in the thyroid gland and then will go throughout the body and act on a variety of cells. And an analogy that we have in our real world today is like how social media spreads. So somebody will produce a social media article and it will then go viral, spread through the networks and have an effect elsewhere around the world. Sometimes that effect is a good effect, sometimes that effect is a desired effect, sometimes it's fake news and sometimes it's not. But obviously when you get to hormones are targeted to specific cells, so there's a match. The hormone will have a receptor which it needs to attach to, and that will set into motion a cascade of events inside the cell or the organ that it's targeted. So the thyroid is one of the key hormones, and I think it's obviously a very common condition, and I think we're going to have a great time discussing it tonight.
Absolutely.
Inshallah.
For me, when I talk about thyroid, it's not something that you commonly know and that you talk about, like the flu, like the diabetes or hypertension or any of those commonly known, but it is. Yeah, and lots of people are affected.
It's very common.
Exactly. So let's kick off with explaining to our viewers what is thyroid disease and thyroid gland all about.
So, I mean, thyroid, the word thyroid actually comes up more commonly than you think. And that's because it's become the villain that everyone blames for all their problems, right?
It used to be the husband.
Yeah.
It's true. I spoke to someone a while back and I mentioned a few things. That, you should have your thyroid checked.
It must be my thyroid. That's a simplistic thing, but actual thyroid disease is relatively common. We see between prevalence rate of 3 to 15% of overt to subclinical partial disease, to put it very simply. The common disease we see is underactive thyroid.
Okay.
This thyroid gland is a gland in the neck. It's a little gland that just sits here above the trachea.
Yeah.
Tiny little gland, and it produces, as Shoaib said, a hormone. The word hormone actually means to set in motion. So this hormone that it produces, thyroid hormone or T4, sets in motion your metabolism, to put it very simply. So it's like a spark plug in every cell that initiates energy production so that cell can do what it ought to do. Makes sense? So the fuel comes from food and everything. It burns it. But you need this thing to initiate the metabolism, you see? So you cannot live without thyroid hormone, and you can't have too much of it either. It will make you a bit jittery, right? And there's complications with that. So the thyroid gland produces this under the regulation of the brain. There's a pituitary gland which can sense how much thyroid hormone is in your body, and that regulates how much you need. So you can get disease of the thyroid. Okay. So if the thyroid gland doesn't work well, it can either become underactive, which is relatively common, or overactive. That's functional disease. Okay, and then you can also get structural thyroid disease, which perhaps is a discussion for another show. But there, the thyroid can also have functional issues, or quite commonly it can be functioning normally, but there's some architectural problem, either benign nodule or in worst case scenario, cancer. You see? So there's functional and structural disease.
So the common structural disease that people may know is something called a goiter.
Okay.
So a goiter is a large thyroid, and it can usually lots of nodules.
A swelling.
And a swelling, and it used to be a very common condition in areas where people were deficient in iodine.
Okay.
So if you had iodine deficient areas, there were lots of people who had this goiter. That was your thyroid trying to react to this iodine.
It's interesting that it's very strategically, through the Almighty, placed in your throat. And explain to us what's all happening with it being there.
Yeah, I mean, it's a relatively superficial organ. It usually is well encapsulated and very well protected. So to see infections of the thyroid, for example, is not very common. It's a well protected gland, it's essential gland. There are rare cases where these days you can get the rare infection. A viral thyroiditis or inflammation of the thyroid can occur, but in general you won't find bacterial infections. There's a good blood supply. It's relatively superficial. Obviously, as you have said, when it enlarges and becomes very large, there's some risk. It can compress the food pipe, the windpipe, it can compress the blood vessels here. So that's where it becomes a problem, even though it may be functioning normally. So that's a surgical scenario. You have to make that assessment separately and then decide whether it needs surgery or reduction in size per se.
I mean, I think just to go back a bit, the thyroid, obviously, the reason a gland like the thyroid will be necessary from an evolutionary point of view or from a survival point of view is that your body's metabolic processes may differ under different circumstances, depending on the weather, depending on how much muscle you have, how much food you take in. So the thyroid hormone level will vary in different conditions, between different environmental conditions, in health and disease. So because of that, it's kept in a fine balance. And as Sandeep was saying, there's a feedback loop. So there's too much thyroid activity and it's picked up that your thyroid is overstimulating your body. It will be picked up in the pituitary gland. It will reduce the stimulation of the thyroid. The hormone levels will go down. If the hormone levels go down too much and the person is not having the metabolic activity that's required, it will be picked up in the pituitary and the hormone levels will go up. And this happens on a minute-to-minute basis. It's not happening, it doesn't take months for this brain to tell that what to do. It does it on a continuous, ongoing basis.
So we understand that the thyroid gland works together with the endocrine system. Tell us about that and how the connection and why most people feel a certain way because of that.
So, I mean, the endocrine system is a vast organ system of glands that produce different hormones. And there's an interplay between all hormones, whether female hormones and thyroid, stress hormones and thyroid. It's very complex how all of these things work. Endo means inside, crine means to split, So, it's the hormonal pathways within the body that form different cascades. And Shoaib was saying, and I also said, it's setting things in motion. So according to our interaction with environments, diet, physical activity, stress, where we live, altitude, temperature, all these hormones are constantly adjusting to your body's need to maintain the delicate balance within you. It's very simple. Of course, it's through largely environmental things, sometimes genetic, autoimmune things, that delicate balance is disturbed. And that's where we get disease, So if we understand the root cause of that balance being disturbed, then we can treat it correctly.
So I mean, if all human beings lived in a room which was the same temperature, with the same amount of light, the same environmental temperatures, woke up the same time every day, slept the same time every day, ate the same things every day, you probably would need a very simple organizational structure of your body. But to allow us to deal with the environments, the challenges, the stress, to move around, to interact, your emotional state, your ability to deal with disease and attacks by environmental toxins, the body has developed this network of mechanisms. So the endocrine system has got many functions, including regulating your metabolism, including, for example, insulin is a hormone. So when you eat, your body produces insulin and it tells the cells what to do with the glucose that's coming in. Cortisol is a hormone which tells your body that your body is under stress and you need to deal with it in a certain way. Adrenaline is a hormone. So there are plenty of hormones. I'm sure some that we haven't even discovered yet. Which help your body to interact with environmental and other stresses. Similarly, the second mechanism that we have to deal with environmental is your nervous system. So your sensory input, your nerves. So there are many different mechanisms, but the endocrine system is one mechanism.
So the thyroid is interlinking with many
all of that.
All of the, our body has to work together. Yeah, exactly.
Yes. Yeah.
And there's more that we need to know about the thyroid, but we'll do that just after the short break with our specialist endocrinologist in studio with us, as well as Dr. Shuaib Wadi. Join us just after this. Assalamu alaikum wa rahmatullah. Very good evening. Welcome back. This is Health Matters, and it is Thyroid Awareness Disease this January. It's almost the end of January, but we still have some time to deal with it. Your questions will be taken live in studio, so please do call us on the number shown on the screen. Do interact with us. This is becoming a common word, thyroid. It's often been blamed, as said earlier, for many things. We have Dr. Sandeep Ruder, endocrinologist, and Dr. Shuaib Wadi in studio with us, our medical specialist. So to get down to symptoms, and I know our focus would have ideally liked to have looked at hypothyroidism, but let's just first tackle the actual symptoms of, I know you need to break it down with regards to the two, but as you said, lots is being blamed on thyroid, and is that really the issue? So take us to some of the symptoms.
So firstly, with any hormonal disease, to simplify it for the layperson, you can either get a disease of too much of a hormone or too little of a hormone.
Okay.
Generally, in thyroid disease, we see a lot more of the underactivity of the thyroid gland, so not producing enough of the hormone. And that's called hypothyroidism.
Okay.
So as we said earlier, the thyroid hormone is like a hormonal thermostat for your cells. You know, if there's a lot of it, your metabolism goes up. If there's less of it, your metabolism gets slow. So if you're underactive, just think of all the symptoms of everything slowing down.
Okay.
Your body temperature goes down. You feel lethargic and tired. It's easier to gain weight. Dry skin, dry hair, low mood. There can be menstrual irregularities, you know. So you gain, your cholesterol can go up. And the extreme version of an underactive thyroid gland, where you have no hormone or very low hormone levels for a period of time, and you can tip over into an emergency, a crisis called mixed edema coma. And that can be very dangerous and has high mortality rate. It means the rate of death with that condition is relatively high if not treated in a very intensive setting. So there's a spectrum of symptoms, very subtle, from fatigue and mild hair loss, low mood, to extreme symptoms, even neurological. You know, you can get sort of imbalance issues and muscle issues and many different things, you know. So the difficulty with the underactive thyroid is that the initial symptoms overlap with a lot of common symptoms we see on a day-to-day basis that may be related to other diseases or lifestyle. So fatigue and weight gain, for example, two most common symptoms that endocrinologists see patients for, you know. So that's where the physician discretion must come in terms of how to test and look at the patient a little more broadly through a good encounter with the patient. It may be something else. So as much as it's common, there's no screening for thyroid disease, you know. We test in high-risk patients where the symptoms are not ascribed to other common things. So if you've got a family history of thyroid disease or other things have been excluded and your symptoms persist despite a good lifestyle, you may want to test the thyroid, and that's a treatable condition.
What's the danger of testing everybody?
Before you answer that question quickly, we've got a caller online from Cape Town. Assalamu alaikum. This is Health Matters.
Assalamu alaikum.
Wa alaikum salam. Dr. Sandeep is in studio.
Can I speak to the endocrinologist, please?
Yes, he is. Doctor?
Go ahead.
Hi. Assalamu alaikum. Yes.
Wa alaikum salam. I'm a 62-year-old lady with being treated at the moment as a hypothyroidism. I'm on altroxin 5 million and 10 million one day. My thyroid was, I was pregnant with my second child, and I was hyperthyroid. Just very edgy, nervous, very uncomfortable, young. With my second pregnancy, it sort of caused me growth retardation with that pregnancy. Spent in hospital about 6 months before I gave birth to the baby. And after the baby, it was still very hypothyroid. I eventually saw an endocrinologist, and he said it's enlarged internally, which I felt I couldn't breathe. I turned the curtains open at night and trying to get breath. I couldn't lay too low down, struggling to breathe all the time. And eventually they decided that it's enlarged internally, and they removed 2/3 of it. This is now 38 years later that I'm speaking about. But at the moment, they confuse me because they can't seem to find the correct diagnosis for me or the correct treatment for me. And I'm suffering a lot, especially today. It was very hard. I'm extremely short of breath. I'm very tired. I'm wobbly. I'm not stable in my hands, just gripping something. And by the time I attend the government hospital, I get to them, I have to go through a long procedure of explaining, and even that makes me more tired. There's times that I feel I just want to cry and just want to lay there and leave me alone, and I just want to stay and wait for myself to be recovered, which happens. There's days that I'm active and strong and healthy, and I can fulfill a good day. And then not too long ago, I had a thyroid meltdown, they called it, where I just slept for about a day and a half and never woke up. But nothing was followed up after that. I was rushing to hospital, stabilized, and woke up the next day. Can't remember anything that happened from the day before to that time. But nothing has been followed up from there. They did mention my PSH and parathyroid glands, and there's not a proper explanation for what is happening. And I'm just hoping that you can give me some answers. Thank you very much. It was a long series. Sorry for that.
It's a pleasure. Thank you so much for your call. We appreciate it. Wow.
I didn't get the lady's name.
What is the name? Hello? We didn't get the name. Do you have a question for her?
No, but just some principles,
Okay.
all right? Whatever the diagnosis was during pregnancy, it sounds like she had an overactive thyroid during pregnancy, and there are many causes of that. It could be a pregnancy-related transient overactive thyroid. It could have been a condition called Graves' disease, which back in the day, they probably, if it was enlarged, would have done surgery.
Okay.
These days we have radioactive iodine ablation, which we wouldn't do during pregnancy, or just if you're trying to fall pregnant. So surgery would have been part of the treatment to get this overactive thyroid to come down and perhaps even render it underactive. The fact that the lady is on altroxin, which is thyroid replacement, it's replacing the thyroid hormone that she's not able to make, means she's underactive. The thyroid is hypothyroid, whatever the cause is. So what has to happen at the age of 62 is firstly you've got to make sure that the dosage is correct for her weight, her age, and for other complications she may have. And the way to adjust the dosage is by measuring your thyroid hormone levels. And the level we use is a TSH level. That's the hormone from the brain that tells the thyroid how much to make. But in the absence of the thyroid, we're supplying it. So that level will tell us whether we're supplying enough or not. If her TSH is still very high, she's undertreating, underdosing, or perhaps it's not absorbing because you're taking the medication with food or iron supplements or something. So the dose may be right, but there's interaction. You've got to take thyroid medication on an empty stomach first thing in the morning. We recommend 45 minutes to an hour before a meal. So if the thyroid level is correct for her age, right? So, and it's not overtreated or undertreated, then usually her symptoms would not be due to that issue, right? You see, there are many other things there. The idea of a meltdown. See, there's only one thyroid crisis. Is when you've got too much thyroid hormone. It's called a thyroid storm. The other emergency is the one I explained where it's underactive. So at 62, it's very important to make sure there aren't other things going on. If you're short of breath on effort, it could be a cardiac problem. Does she have high blood pressure, cholesterol issues? What's the weight, you know? So these simple things I think first need to be looked at and make sure the heart is okay, make sure the thyroid level is okay, and check those two, and if they're stable, then you can look at the more esoteric causes. I don't think parathyroid gland is a major issue in terms of these symptoms, the way she was talking, you know? Obviously that's, I'm just giving a reply based on what she said.
But it does sound quite debilitating.
I think one of the things that happens, especially with patients like her who's had lots of different complications and needs access to a specialist, she is right that it can be very difficult to get access to a specialist through the state sector. We know that there are issues with access to care in the public sector. There may be multiple bureaucratic obstacles put in the way of patients. But what's really fallen by the wayside is the sort of relationship with a general practitioner. So I would really encourage this type of person who's got multiple issues, who can't get easy access to specialists in the state, to develop a good relationship with a trusty and good general practitioner who's then able to do some of these basic things, check the TSH level, make sure that there's no obvious cardiac or other disease, and then direct her towards a specific person that she needs, so she doesn't have to start again. Because she's right, if you go to a state hospital, sometimes you meet a completely new person you've never met before. They don't know your history. Sometimes the notes are not accurate, and they have to start again, and it really can be frustrating. But if you've got a general practitioner who knows you, who's overseeing you, they can summarize everything and refer you to the appropriate doctor. And I think sometimes that doesn't happen.
I think it highlights a lot of the issues, like, you can have all the right treatment, but in terms of the public health care issues, access becomes an issue. So
you've mentioned, this happening to your body every, few minutes and changing. And how often should you then be visiting your GP just to keep managing?
So that is a difficult thing. You're right. You can't. As Sandeep will tell you, It's very difficult to adjust the amount of thyroid hormone you take in on a day-to-day and moment-to-moment basis. Even thyroid replacement therapy at best is going to be a substitute for what your body is able to do on a minute-to-minute. Like all hormone replacement therapy. For example, if you're diabetic and you need to take insulin, it's not as good as the insulin the way your body makes it. It's already a compromise. But certainly you should be following up regularly to make sure your dose is adjusted, and there are things you should be doing to make sure.
Perhaps just some principles to reduce stress with the patients, right? I mean, thyroid hormone, the actual hormone T4, has a long half-life in the body. Half-life means how long the hormone lasts in the body before it's eliminated.
Okay.
So it's about 6 days, 6 to 7 days actually, right? Okay. So the thyroid hormone replacement therapy, whichever drugs they're using brand, the drug is levothyroxine, is designed in a way that it lasts. So once you reach stable levels, it's your weekly dose that's important. So generally the dosage is worked on the type of thyroid. If you've got a full underactive thyroid, you'll need a higher dose, and most people will stabilize around 1.6 micrograms per kilogram, give or take a few, If you've got a partially under, what we call subclinical hypothyroid, we start at lower doses. Okay. If you've got heart issues and stuff, we may start with a lower dose. So that's one principle. Then once you've started a dosage, you've got to take it properly, as I described earlier, for 6 to 8 weeks, generally 8 weeks, before we recheck the levels. Okay. So it's not that the change is going to happen in a day or two, a week or two. We've got to be patient enough for those 6 to 8 weeks for that axis to recalibrate, right? And that level will then tell us accurately whether we're still dosing, underdosing, overdosing, or we even, you see? And then you make a change. So when there's a change in your dosage, you need to follow up in about 8 weeks again. Okay. But once you've reached stable levels, most patients just need to check that level once, and mostly twice a year at most.
Yeah. Very interesting. We'll continue with Thyroid Awareness Month just after this with specialist endocrinologist in studio. Back in a moment. Assalamu alaikum, welcome back. A very good evening. I'm Khawa Salman. With me is Dr. Shuaib Wadi, our medical specialist in studio, as well as endocrinologist Dr. Sandeep Ruda. Thank you so much for your time. It's an absolute pleasure having your sort of expertise in studio where callers can phone in and ask their questions. But it does also quite sound like this is sort of a lifestyle thing. It's a life-changing thing, in fact, for someone to be having a thyroid issue for years and years and years, and you need to now adapt a certain lifestyle and changes within you. So maybe we can latch on to what you spoke about earlier on, and how the little things that you need to do, sort of matters, whether you keep a diary, whether you have your blood tests regularly, whether you need to really understand the disease.
Yeah, so maybe a couple of practical points around that, right? Once you've been diagnosed, so we're specifically talking about an underactive thyroid, for example, now, which is
So
common.
that's hypo.
Yeah, hypo. So these patients need to take treatment to replace the hormone that the gland is not making. So unfortunately, we've lost that automatic regulation.
Okay.
So we got to do it from outside, which means there has to be some consistency and pattern to maintain the levels at a stable level. So thyroid medication must be taken at the correct dose. We say first thing in the morning on an empty stomach, at least an hour before a meal or other intake, right?
So first thing in the morning,
Yeah,
no
so
eating, so when you wake up,
practical advice, we tell our patients to keep it in a pill box next to the bed with a glass of water, and upon rising, you drink it. Then at least it's out of the way, and you go and brush your teeth and get ready and all of that, and then 45 minutes have passed and you can have breakfast. So that's an easy way to do it.
So also that break between breakfast and taking your medication needs to be there.
Yeah.
Okay.
Right. And the other thing is if you're on other medication, like we were talking, proton pump inhibitors, so ulcer medication, or iron tablets, they must be taken at least 4 hours apart in most cases from thyroid medication, because those medications will impair the absorption. So you're taking it, but they don't get absorbed then. So these are little things we need to know.
And there can be big practical issues because some of those medicines also need to be taken on an empty stomach. So it becomes a bit of a tricky thing.
You may need to time it, those at
one
lunch,
in the morning, one at night,
in the evening.
And then you still forget as well.
Absolutely.
Yeah, but in these days of apps and watches that remind you of everything, it is probably
remind
no
yourself
excuse.
to remind yourself.
Yeah.
And then the other thing with the thyroid in terms of practical advice is if your levels are fine and you maintaining a healthy lifestyle, you should be okay. But if you're not feeling well, first address the simple issues with your GP in terms of dosaging and how you're taking it. But remember, once you have a thyroid illness, you are not the thyroid gland as well. So you're a human being with many things going on. If you're sleeping late, eating badly, smoking, not exercising, there may be other reasons for your symptoms as well, right? In terms of keeping a diary for your checkups, you don't need a detailed diary, but you should keep a track of your doctor's appointments. As we said, if you're adjusting dosages, you should follow up in 2 months, and then make sure you have that blood test on time for your doctor's visit. And it's very simple after that, right? Often questions come up about diet for thyroid. And we look at the scientific data and we give objective evidence. You can't give feelings about things. So the good advice for most patients is not to follow any headline diets or fad diets for thyroid, right? Because people will tend to overeat or undereat a thing, which may then have detrimental effects on the rest of the body. The thyroid gland in general is a protected gland. The American Thyroid Association recently had a workshop on diets and thyroid, and they said very simply, there isn't a specific diet for thyroid. In iodine deplete areas, you need to supplement iodine, and in most cases patients need about 150 to 150 micrograms.
It's pretty rare these days because most of our
salt is iodated. Right.
Oh.
And you can get iodine in fish and that sort of thing. Most pregnant women are taking vitamin supplements that have iodine, so it's very rare to get iodine deficiency. But the fadism that's created, especially on the internet, may result in a situation where people take too much iodine, and that's also bad. Because less iodine can cause hypothyroidism. Too much iodine can cause over and underactive thyroidism and deleterious effects.
Disease in general.
And even with all these thyroid diets where they talk about broccoli and kale and all of that, must avoid it. It's not so much the cruciferous vegetables themselves. It's something called thiocyanates in them, which vary, and usually it concentrates when people juice their food, and that's which we suggest you don't do. So eat your food in a healthy, balanced way. We say 1/3 food, 1/3 water, 1/3 air. So you don't have to overfill yourself. But the definition of food is things that come from the ground. We got a rule in our practice. If it comes from a factory or it has an advertisement, try and avoid it. Right? These simple, practical rules are useful, and then you don't overdo it. So a patient with thyroid disease is a whole human being, and that's just one element. That can be easily maintained through some practical guidance, a little bit of discipline, and regulation. And then anything else, we must look at the rest of the body too in interaction with the environment.
But of course, you want to understand thyroid, so you're going to Google and you're going to ask questions and you're going to go on the internet and
that's the problem with fake news, and you have to be a bit discretionary about what you find on Google, because there's a variety of topics around which you can find information which is completely untrue.
So any books or websites that you would recommend for people to read up about thyroid?
No, I think the best thing is to speak to a healthcare professional. Okay. You see, the important thing here is about having objectivity with all information today. That's independent investigation of truth. Sometimes we like to read what we like to hear.
Yes.
That comes from ego and wanting quick fixes, instant gratification. That sounds right, so we'll do that. And this is about being human. It's a bit of a philosophical subject, actually, where we watch our mind and its desires and say, hey, if it sounds too good to be true, usually
it probably is most of the time.
Yeah.
Right. And there's an old saying an old man once taught me, poison now becomes nectar later. So we do the difficult things, wake up, exercise, do the right things. It's hard now, but it always reward you. So we do easy things quickly. I mean, there's some supplements now for weight loss and things, on the market, claimed as natural, but they've been spiked with, thyroid hormones and that sort of thing. So you've got to be very careful.
I think that's an important point that Sandeep has brought up. There are some people who are giving patients thyroid hormone, even where their thyroid function is normal, to help them to lose weight. But there's a significant danger. Maybe we should just touch on hyperthyroidism a little bit and what the dangers of hyperthyroidism
Yeah. So, I mean, we spoke about hypo, which is underactive. And look, the long-term complications we haven't mentioned of underactive thyroid. It can lead to cardiac disease, depression, many issues. You can get heart attacks through high cholesterol. So that's why it's treated not just for feeling well, but to prevent these complications. Now, an overactive thyroid can be due to many causes as well. And the autoimmune cause of that is called Graves' disease, where antibodies stimulate the whole thyroid gland. And that's by far the most common cause of overactive thyroid. Then the condition of thyroid toxicosis, meaning too much thyroid hormone, can be due to taking thyroid hormone from outside. Either a person who's underactive, who's overdosing, or as you have mentioned, people using it for other problems, to lose weight. And this is very common. Now, remember we said it's like a hormone that regulates your thermostat. So your engine capacity is so much, but now you're turbo boosting the whole thing.
It up.
You're revving it up. So your heart can start beating very fast. You can get an irregular heartbeat. We call it atrial fibrillation. You get an irregular heartbeat, you can get a clot in the heart and a stroke. We've seen this, with the patient. You can thin your bones, get osteoporosis, dementia. There's a condition called thyroid storm, If you got predisposing risk factors like smoking and cholesterol and you overactivate the heart, you can precipitate a heart attack. So it's not good to tinker with your physiology if it's normal. God-given physiology, you must leave it as it is.
We've got a caller online. This is Health Matters. Assalamu alaikum. Good evening. Wa alaikum salam. You may go ahead. Endocrinologist is in studio.
Sister, I was on 50 milligrams on altroxin, and now I'm on 150 milligrams. And I have a sleeping problem, and my cholesterol also is very high. So what should I do about that?
Do you have a question for the caller?
I have a response.
Okay. Thank you so much for the call, Shukran. We appreciate it. You can listen on screen, yes, on your television.
Yeah. So she said a couple things. First, she was on a lower dose, then on a higher dose. Her cholesterol's high and she can't sleep, right?
Okay.
So if she was on 50, it's usually mcg, micrograms of thyroid replacement therapy, and the dose was gone up. We have to assume that the doctor did a test and her thyroid levels were still underactive, meaning the TSH was high. So you increase the dose according to the need and the weight. Generally, if your thyroid is underactive and you're not dosing enough, there is a correlation with a higher cholesterol. And as you treat the thyroid appropriately, the cholesterol comes down.
Okay.
However, if your thyroid level has normalized and your cholesterol is still high, then there are other causes for the cholesterol, which is diet, lifestyle, maybe a genetic thing as well. So we need to look into those things, right? If the sleep problem came later as the dose increased, there may be a concern that the dose is too much then.
Okay.
They may have
The turbo boost we told, overcorrected, right?
Okay.
So if the TSH, the level is right on the dosage, then the insomnia is not due to that. Then you address
But
other
I think
causes.
once more, you can't replace a proper physical examination and seeing your GP, because there's so many different things. For example,
Variables,
if you're hypothyroid and you're very overweight, you could have many other reasons for having difficulty sleeping, from sleep apnea, and we've had discussions before about sleep apnea, to depression, to many other things. So I think it's worth getting those problems together and seeing your doctor and explaining those problems individually and then letting him try and put it together and see which are related to the thyroid disease, which may be corrected by proper replacement, and which are unrelated or could be contributed to by other things. Because by the time you hit 55, 60, 70, sometimes you've got like a collection of problems. Thyroid, arthritis here, something else there, some medication did something there, wife is troubling you, the kids are troubling you, lots of different issues. So you need to tease all that out.
I think ultimately, especially with thyroid, you actually need to be managed, as you said earlier on, Dr. Shea, by a specialist physician or your GP. And this is something that it's not a quick answer
Well, as a doctor, you're not going to treat one organ, and some people tell you that. You're not going to say, okay, hello, Mrs. Thyroid. How are you today? It's hello, Mrs. Solomon. This is what are your problems, not what's your thyroid's problems. And then we're going to have to dissect which are related to the thyroid and which may be something
Absolutely.
else.
Correct.
But your entire body works
all
together.
connected.
And today we are looking at highlighting Thyroid Awareness Month with the endocrinologist in studio. We take your calls just after this. Please stay with us. Assalamu alaikum, welcome back, a very good evening. Our last few minutes of the show, it is Thyroid Awareness Month. And remember this, it doesn't end here. This is a lifestyle change. This is something that you need to, interact with your specialist doctor, also your GP, have someone manage you. And as Dr. Wadi said earlier on, it is something that's happening, every minute, but still psychologically, and I think your whole body works together to try and understand everything what's going on. We have Dr. Sandeep in studio with us. Please call in with your questions, thyroid questions. Dr. Sandeep, specialist in studio with us. Dr. Wadi, our medical specialist as well, joining us. So Dr. Sandeep, you've been quite active, with keeping people sort of obey with what's happening with their thyroid. You are consulting at Charlotte Makeke, associate lecturer at Wits, still very much in the industry, so you know what's happening and what's evolving. And to understand this disease holistically, one needs to approach it like that. So please take us through, before we get into sort of weight, because it's a big thing, weight in thyroidism, loss and gain. But quickly, thyroid and pregnancy, how is that affected?
It's very important. Look, first of all, during pregnancy in an otherwise healthy patient, there's changes that happen to the thyroid gland, especially in the first trimester. The thyroid becomes more active, it may enlarge a bit. There's a cross-reaction with the pregnancy hormones which stimulate the thyroid gland. So in that first trimester, especially women who have this condition called hyperemesis gravidarum, the excessive vomiting, morning sickness, all of that. They may look like... I
didn't know there was a condition.
So because of the high pregnancy hormones, the thyroid may be overstimulated. Now in that case, there's no problem with the thyroid, it's just overstimulated. So you've got to be cautious in those instances in the first trimester that you don't unnecessarily treat it. You've got to have a correct assessment.
There probably is a physiological reason why that your placental hormones cross-react with the thyroid and substimulate the thyroid. It may be related to
the developing fetus in terms of its metabolism. Initially, the thyroid is not formed in them. So to give a very simple explanation.
We'll get back to that in a minute. We've got a caller online. This is Health Matters. Assalamu alaikum. Good evening.
Hello, how are you?
Very good, thank you. You may go ahead. We have endocrinologist in studio. What is your question?
I was diagnosed in 2016.
Yes.
In 2015 with hyperthyroidism.
Yes.
And they later said I've got Graves' disease.
Yes.
And I've been on medication ever since, and my thyroid is not normalizing. And then last year, on the 31st of May, I had radiation done. And then this year I was told that it was not successful and that I need to repeat it. So I'm having my scan on Friday. So I think the radiation is going to be maybe a couple of days from then. So my question is that what are the chances of it not working if it did not work the first time around? And I find myself that I'm gaining so much weight. It's just so uncontrollable.
All right.
And I don't know what to do. Like I'm feeling heavier and heavier.
Okay. Who am I speaking to?
You're speaking to Nkuli.
Nkuli, thank you so much for your call. Doctor, do you have a question for her?
Just one question.
Okay.
Are you still taking your thyroid medication?
I've stopped for 2 weeks. I was asked to stop.
Yeah.
For 6 weeks, I think they said.
Yeah. So
You can listen on your screen. Thank you so much for your call, Nkuli. Yes.
so
All right, thank you so much.
So in Cooley's case, she's been diagnosed with Graves' disease, which is an overactive thyroid.
Okay.
And there are a couple of ways of treating it. You can use anti-thyroid medication. So this is medication to lower the thyroid hormone, right? And that medication can be very effective if used appropriately over a period of time. You can sometimes wean patients off. There's a small possibility of remission.
Okay.
Generally, if they relapse or it's not controlled with the medical treatment, we go for a therapy to put the thyroid gland down, so to speak, so make it rendered underactive, basically. So in the old days, that used to be surgery or if it's enlarged. But now there's the therapy of radioiodine ablation. So iodine is only taken up by the thyroid gland, and if it's radioactive, it will destroy the gland. No surgery, no pain generally. The science shows it has usually no fallout to the rest of the body. So the type of therapy she had was an ablation, and it was some months ago. Sometimes it takes 3 to 6 months for that radiation therapy to have an effect. If it hasn't had an effect, you may sometimes need up to 2 more treatments, but generally it is effective.
I think the key, as Sandeep said, is that the iodine, it's a very effective treatment because iodine is actively taken up by the thyroid. So, and the thyroid concentrates it because it needs that iodine to make the thyroid hormone. And there's nowhere else which really takes it up.
Okay, so it working or not the second time?
So it should work. We've had patients, it's rare, where by the second, sometimes rarely the third. I can say in the last 10 years, probably like 2 or 3 patients that needed 3 times, you know. But there's one thing that isn't in keeping with Graves' disease is if she's, the weight gain, you see. So my advice would be for this patient to once again see the GP, just make sure the weight gain isn't due to other things. So with an overactive thyroid, usually you lose weight. She's on treatment, so it may have normalized. But the question is whether she's over-treated, but there may be other reasons for the weight gain.
We got another caller. This is Health Matters. Assalamu alaikum. Good evening. Wa alaikum salam. We have endocrinologists in studio. What is your question, sir?
I'd like to ask the doctor that if you're on treatment on the thyroid, alproxen, and if you're on other drugs like anti-inflammatory or cortisone or so forth, can that reduce the effect of the alproxen?
All right, who am I speaking to?
Sorry?
Who is calling? What is your name?
Yusuf.
Yusuf, shukran so much for your call. We appreciate it. Doctor, do you have a question for him?
So as we had said earlier, generally if you're on other medication, you should take it sometime apart. The ones we know of that do cause an issue are the antacids, and iron tablets are common, right? It's interesting you mentioned cortisone, right? Usually cortisone is going to enhance the effect of thyroid hormone in your body. So you need to know that. There are patients who have a form of underactive thyroid, which is due to the pituitary gland being damaged. The signal is not working. And they may have other hormone deficits. So they don't make cortisone and they don't make thyroid hormone. Those patients have to be on cortisone before they go into thyroid hormone. Otherwise, you can precipitate a crisis, you know. So it's difficult to say in this gentleman's situation. You know, he's on anti-inflammatories and he's on cortisone. So it sounds like he's got another inflammatory disorder, you know, which rheumatological perhaps or something. So he needs a specialist to go through it and tease things out.
You were pointing towards your knees, so something to do with the bones or the joints.
Usually.
Psychologically, you were doing that.
Cortisone itself is a hormone. So it's a hormone which is normally produced in your adrenal gland, which has got a specific function in your body. But obviously it has anti-inflammatory properties and anti-immune properties, which is why we use it therapeutically.
All right. We've just got a few minutes left. It's our last caller. Let's go to it. Assalamu alaikum. Good evening. This is Health Matters. Hello? You may go ahead with your question.
Hello?
Yes, hello. You are live on air. We have endocrinologists in studio. What is your question?
Good evening. You are speaking to Sam.
Hi, Sam.
Hi, you're speaking to Suzanne.
Yes.
What is your question, ma'am?
Yeah. Ma'am, I need to find out from you.
Yes.
I did have a cyst on my thyroid,
Yes.
and I had 2 operations.
Okay.
And I'm now on medication,
Mm-hmm.
and I've been to the doctor 2 weeks ago.
Okay.
And for my first operation, I was on no medication.
Mm-hmm.
And then I had my first op in 2009.
Okay.
And I had my second op in 2000. And the other one was 2017, my
Okay.
second op.
Sure.
And for my first op, I was on no medication. For my second op, they said when after my operation, I will go on medication.
Okay.
So when I've had my op, my first medication was, my first medication, my dosage was 50 milligrams.
Okay.
And then thereafter they put me on 100 milligrams.
Okay.
Then thereafter I see they say my thyroid levels are a bit high.
Ma'am, can I ask you to turn down your television? Because there is an echo and we can't hear you very clearly. We just have a few minutes left. What is your question? You need to turn down your television.
Yeah. And then
Okay.
I've been to the doctor 2 weeks ago.
Yes.
And now I'm still on the 100 milligram.
Okay.
So now being on the 100 milligram is making me lose weight.
Okay.
So I want to know what's the cause of me losing weight.
Okay, sure. We appreciate your question. Jazakallah. Assalamu alaikum.
Okay, so another complicated one. No, it's look, obviously through the show,
Yes.
we can't say with certainty.
Absolutely, yes.
When you got weight loss, I'm not sure the lady's age, but if it's an
Okay.
elderly patient, you've got to see your doctor to make sure the weight loss is not something sinister.
All right.
But if it's the thyroid in this case, there's a possibility it's over-treatment. The dose is too high.
Again,
Very
okay.
simple, and that needs to be adjusted according to the level. But make sure. Just nice, maybe just to mention on thyroid cysts that you mentioned.
Yes.
You know, the thyroid is a cystic gland. It means it's made up of little cysts in which the thyroid hormone is made.
Yeah.
So as we said, you can get structural disease. So structural disease, you can get an enlargement of the whole thyroid or part of it.
Okay.
If it's just a cyst, we call it a colloid cyst. It's a benign issue. It's just filled with a lot of fluid. And that can be diagnosed on sonar. The problem becomes where you're concerned about cancer. So sonar of the thyroid, a simple non-invasive test, can determine whether those nodules look suspicious or not.
Okay.
So in good radiologists' hands or good endocrine sonographers' hands, they'll be able to tell whether it's suspicious, and those ones need a simple biopsy. Just for patients to know that that's the approach. You know, you put a needle in and you can tell this is benign, nothing to worry about,
Okay.
or this is suspicious or cancerous, in which case then you pursue that approach to treat it aggressively, you know. And then there's the goiters we spoke about, you know, they're enlarged. They may be functionally normal, but you can also get enlarged thyroids that have areas of overactivity, and then you need nuclear scans as well. Right?
Thank you so much for that. We have 30 seconds to wrap up. Doctor, please, your final concluding comments.
I think maybe just one key message is that don't forget you're a human being. So you're not just a thyroid gland, you know, and that's part of things. But there's bigger things to do. Get it stable, get it sorted, get it out of the way, and continue with your life purpose is important. And that's
Great stuff.
important.
We
Okay.
appreciate your time.
Thank you.
Dr. Wadi?
No, I think it's just Sandeep said everything. I think patients need to take responsibility. It's one thing that we often find that's missing. They're expecting someone to, you know, even take their medication for them. So you need to take responsibility for those things which are within your control. If it means taking your thyroid medication in a certain way or whatever medication in a certain way to try and optimize your health, and you're the only patient you're looking after, then try and look after yourself as well as you can.
Well said.
The doctor's job is to teach, he doesn't heal.
There we go. Yeah. Holistic, everything what's happening in and around you, inside and out. Tell the doctor whatever you need to do, whatever is happening, be truthful and sort of share the message of thyroid, and your closest connection is your medical professional. So find out as much as you can. Go there with all your questions. As Dr. Sandeep mentioned earlier on, they're the best ones for the advice. Thank you so much. Shukran so much to you for interacting, being part of the show. Wear your blue ribbon, blue paisley ribbon for Thyroid Awareness Month, January. From myself, Hawa Solomon, wassalamu alaikum and goodbye for now.